Good afternoon. I'm sorry,
The slides, please, yeah.
I was in the simulation center because everybody wants to do minimal invasive mitral. So I was given a very good wide spectrum of talk. So bear with me and try to deliver this message in less than 15 minutes. Can I move the slide? Okay, so mitral valve, it's the most posterior structure in the heart. It's a very complex structure because the leaflet itself, the mitral itself is not only leaflets, it has subvalvular apparatus, it has annulus. All these play a major role in the function of the mitral valve. So this is how the mitral valve looks like when you do a surgical exposure for the mitral valve. You see the anterior leaflet, posterior leaflet, you see the annulus, and also you look into the subvalvular apparatus of the valve, which play a major role in a repair. As a surgeon, you have to be very vigilant about what are the structures that are close proximity to the mitral valve. And as you can see here, the mitral valve has attachment into an aortic valve. It has also close proximity to the it has close proximity to coronary sinus and the conduction system. And that's why when you repair a mitral valve or you do a mitral valve replacement, you have to be aware of all these structures around you so you don't go in trouble. For example, if you take a deep bites in this area, you will end up with a circumclusion. You can cause coronary sinus injury, a heart block, and aortic valve injury. So also you have to keep in mind, how does the valve should function? To have a really functional valve, you should have a coaptation between 7 to 9 millimeter, posterior leaflet length between, sorry, I don't know why the slide is moving, 5 to 6 millimeter, and anterior mitral leaflet length about 15 millimeter. This will give you the perfect setup for a functional mitral valve. And we also have to keep in mind what is the subvalvular apparatus, because there is primary cord, there is secondary cord, there is sometimes tertiary cord, we call them the basal cords. All this also play a major role in the function of the mitral valve, and we have to keep in mind when we repair these valves. So when we repair a mitral valve, you always think about carpentry classification of the mitral. Is it type 1, what you call the functional? It is type 2 when there is a chordal rupture or chordal elongation. It's type 3, and type 3 has two types. Is it ischemic or it's rheumatic? All this is important when you encounter a mitral valve repair. And there is a pathognomonic continuum of degenerative mitral valve. You could have what you call the FED, which is a fibroelastic deficiency. This can be only a chordal rupture, or you could have the full posterior leaflet that rupture, or you could have what you call the deformifrost, which involve the whole posterior leaflet, and it goes to very complex, which is Barlow's disorder. If you look at the STS database, you can find that mitral regurgitation is the most common mitral pathology affecting adults, and degenerative affect 3% of the population. So we expect to have a very large number of patients will come for this procedure. And if you look at the guidelines, mitral valve repair in the patients above whose ejection fraction is normal and symptomatic, still the class 1 indication for surgery. And if you think, should I repair this valve early on, even if the patient does not have symptoms, and data support that. Because if you have a patient who comes with you and with very minimum symptoms, if you repair them, compared with medical therapy, they have a better survival. And actually, it met the survival of normal population. And if you look at the 5-year outcome of repair versus replacement, because some people in some centers, they're not advocate of repair, they just do the valve replacement. Valve repair is always better than the replacement. The patient will do better from survival point of view. And this is also was clearly demonstrated in different studies and even meta-analysis. You can see here, if you look at the 30 days mortality, mitral valve repair has a better outcome. If you look at the 5-year survival, mitral valve repair still have a better outcome than mitral valve replacement. How do we approach the valve? There is too many ways. You can do that conventionally. You could do that with direct vision thoracotomy. You could do it robotic. It doesn't really matter how you approach it. The most important thing, give the patient a good repair. When you do a mitral valve repair as a surgeon, you have to have a very good valve analysis. You have to be systematic. You have to check every area and make sure when you plan your repair, you have a full understanding of the valve. I'm not going to spend time on how do we repair it because will take us a long time. But basically, anterior mitral leaflet, there's 4 main things we can do. Either a small application for the valve, we could do chordal transfer, secondary cord to primary cord, or we could do chordal transfer from the posterior leaflet. But the new emerging things, artificial cord. Artificial cord is our friends. It's easy to be done. It's very good. Outcome is excellent, and you don't need to change anything in the valve geometry. There is a lot of techniques being described to not touch the leaflet, just go to the subvalvular apparatus, which is the muscle. We don't do this anymore because this required a lot of judgment. Sometimes you ended up ruining the subvalvular apparatus and end up with not very good repair, and will be very difficult to recover this. But there is still some techniques being prescribed. Posterior mitral leaflet, it's the most common valve that we see for a repair. There is too many ways of repairing it. You could do, and this depends on in which spectrum you are. Usually you can do a very limited resection, like we call it a triangular resection. But when you do triangular resection, you have to be very vigilant. Why? Because you don't want to end up cutting too much leaflet and then suturing it together and then open the cleft. So in this case, you do a quarangular resection and you do a annular application, so you will have enough tissue. If you have a very long and you need to do a very long resection, you could do either, as I said, application for the annulus, or sometimes we call it a slide-plasty. Sorry, when you cut the leaflet and you bring it in the middle and then you suture it together. The mastery of repair is a ring. You have to use a ring. Ring has to stabilize the annulus. It's not enough only to tackle the leaflet, but ring, it has to be done. You could do the suture has to be placed carefully in the annulus. You could do it in any ways you like, but the most important thing is you have to make sure you're in annulus. So, if you look at the durability of a mitral valve repair, there is a lot of papers comes in chordangular resection, which shows an excellent outcome, which is freedom from a mitral regurgitation. And also, if you look at if you look also as a triangular resection, you could see also if you do a quadrangular or triangular resection, you can still end up with excellent outcome from survival and freedom from a mitral valve regurgitation. However, when the chordal reconstruction came out, people start thinking, doing chordal, am I going to get the same outcome as I do with the resection? And the answer came as yes. There was no difference in terms of freedom from MR and from survival. However, intermediate result of the non-resection, which showed also a very good outcome, and that's why people start thinking, do not cut more, reserve the leaflet. Why is that? And I'll show you next, because when you cut the leaflet, sometimes you lose the motion of the leaflet, and this will affect your hemodynamics of the valve. And for that reason, people start thinking, if I do, let's compare chordal replacement versus leaflet resection. And if you look at this, there was a favor in terms of a new cord, of survival, and also for a valve function. And this is actually, now people start changing the paradigm. 20 years ago, we used to do a lot of quadrangular resection. And then people know, okay, let's do something else. Then they go to quadrangular resection and slidingplasty. Then people start to do LS, which is triangular resection. And then let's do foldingplasty, do not cut anything. And now a lot of people, they do chordal replacement. This paper was published by my mentor, Vinay Badwar in West Virginia. To have 4 main principles of mitral valve repair, you have to look at the depth of the coaptation should be more than 5 millimeter. You have to stabilize the annulus. You have to restore a normal leaflet function, and you have to achieve a repair with mild or less post-operative echocardiogram. This is a paper I published about what is the technique for mitral valve repair, and depending on the pathognomonic feature of the mitral valve. I'm not going to go in details, but each pathology, you should have a systematic way of repairing the valve and have a good approach to each of these diseases. Now, if you look at what is the trends in the mitral valve surgery from the society of the STS society, we see that the mitral valve repair have excellent outcome, low mortality, and low morbidity. So mitral valve repair still has upper role in terms of compared with valve replacements. And you can see here that the volume of the mitral valve repair it growed over the time when the people gain experience about how to repair the valve and change of techniques. And if you look at different approach, let's say conventional versus minimally invasive, there was no difference. If you're trained to do minimally invasive surgery, you could still get excellent outcome in the repair in terms of survival and in terms of freedom from mitral regurg. And now a lot of people talks about robotics. This is from our center. Should we do robotic surgery for a mitral valve?
Dr. Alreshidan, just like a small interruption since we went to robotic, I would like to hear from the panelists some few points.
Absolutely.
So, Dr. Adil Tash, what do you think so far? Your thoughts about the type of repair, the placement. What is your go-to now before we jump to the?
I totally agree with Dr. Rashidan's last statements, which is we are moving towards more respect rather than resect. So we try to avoid resecting any parts of the leaflets, and fixing the apparatus, the chordae, is probably the way to go. Yes, I do.
Dr. McKenzie?
With stabilizing the mitral with the ring. Yes.
Dr. McKenzie?
Yeah, thank you. I think that was a fantastic introduction to the topic, and I think one of the key take-homes is the systematic valve analysis. And the challenging point for you as a surgeon is most of the time, once you're in there, you see the mitral valve just from the atrial point of view, and you don't appreciate how it looks from underneath. I think that's where TEE and imaging plays a significant role to understand the subvalvular apparatus and really, the distances from the cords to down to the leaflets or up to the leaflets, however you want to look at it, and the papillary distance and all of those. Really eye-opening to see with the 3D if you're focusing on the best image.
Dr. Zakaria, you have any thoughts from imaging perspective since we just touched bases?
I think full assessment of the anterior mitral valve leaflet length and posterior mitral valve leaflet as well length, and the amount of tethering, it will also has role in a better outcome in repair, especially we're talking about functional, more of functional MR. We prefer repair, definitely. We are trying, we love to have a good repair rather than the replacement during the surgery. Yeah.
Okay. So any follow-up comments, or you want to proceed with the?
I'll proceed. So why should we do robotic surgery? Because we have a lot of data and literature which show that doing robot operation will not increase your probability to go back for surgery, and you will have also a good survival. And if you look at the durability of robotic mitral valve, you could see that the freedom from a MACE or freedom from significant mitral regurg was very significant, more than 87%. And most of the people, they stayed in the mild and lower range of MR. And if you look at, people think about cost. I'm doing robotic, I'll have more cost. This is not the case, because you could see here that when you do more cases, your cost will be adjusted and you will have a very good cost saving. And this is reflected really on a patient, because we patients, our center, patients have a better quality of life, they have less pain, and they go back to their physical activity in much shorter time. And it's not only that, for us as a surgeon, I get this tool, I can do more complex repair, because this is showed clearly in multiple studies that doing more robotics, you will be able to repair more valves. Should we do arrhythmia surgery with a mitral valve? Of course. Why should we do that? Because there is a clear survival benefit. If a patient comes with mitral valve disease, with atrial fibrillation, doing a MACE procedure or ablation, this will affect the patient's survival. And if you look at this, it will be actually match the people who have no atrial fibrillation. And also, we're doing simulation today. We have a systematic way. I also published this paper in terms of how should we do this, and we can do this with multiple energy therapy. I use it with the cryoablation, and we have excellent outcome. So we do that for any kind of disease, redo, minimally invasive, regular, repair, replacements. We have done so far more than 100 cases in King Fahd Medical City. Our first year freedom from atrial fibrillation was 94%, and our freedom from stroke was 98%. And this is clearly demonstrated in multiple guidelines, which is STS guidelines, telling us that doing atrial fibrillation surgery during mitral valve, it's class 1 indication. And I will not close the loop here, because not everybody can go for surgery. Sometimes there is a high risk, as Dr. Mahmoud mentioned. So TARE still play a role. It's not class 1, it's still class 2B. However, not everybody can go for TARE because of the complex anatomy. As you can see here, you can have a very expert or high volume center that can do a mitral valve area less than 3 millimeter, or the depth is less than 7 millimeter, or sometimes rheumatic or severely ischemic. That's why there is a new emerging technology, which just give me
1 minute, yeah.
2 minutes.
Ziad.
Which is, if you are expecting to have additional mitral stenosis or expected to have a very short posterior leaflet or cleft, then we can go for Tendyne. So Tendyne can be done for any kind of primary MR, secondary MR, because if you do a clip and you ended up with significant mitral regurg, you will affect the patient's survival, and this is clearly demonstrated here. This can be done in any kind of, as I said, in mitral regurg, and this is actually a theme which will give us which patient will benefit from Tendyne. The 2-year outcome in the first study, the patient have a lot of all-cause death and cardiovascular death, but this group was very difficult group of patients. They were prohibited for surgery, and that's why we see a lot of death. But the good news is that most of these people, they have no MR, and they have a good New York Heart Association class, and there is improvement in their quality of life, and there is no hospital readmission for heart failure. We do this procedure by doing a lot of planning. We look into the valve size. The most important thing when you do transcatheter mitral valve replacement, you have to be very vigilant about the new LVOT and LVOT obstruction. That's why we do a lot of calculation for that. Then we simulate the valve in real life, and then we do that in the hybrid cath lab between surgery and interventional cardiology. We deploy the valve, and you can see that how this valve looks like in a patient that they are not good for TARE. So in conclusion, mitral valve is a complex structure. You have to hold full understanding for it to be able to repair it. Be systematic in assessment and repair. Repair is superior than replacement, even in old age group. Minimally invasive, it has better quality and faster recovery. Robotic is an emerging technology. It will have a better resolution for surgeon. Mitral valve disease is associated with high risk of atrial fibrillation. Please, when you have patients with AFib, do MACE for them. High risk cases can be considered for TARE. If TARE cannot be done, Tendyne is a vital option. Thank you so much.
Thank you, Dr. Alreshidan.